So welcome to the next session of the video series on the scapula. The first series, we looked at the basics of the scapula and scapular dysfunction. Now, let's take that basic information. Everybody's got it now. And we're going to take it to the exam room. Okay, so the first question is, what are you really seeing when you observe this asymmetrical scapula? Okay, so you've taken this patient, he's a patient with shoulder or arm pain, and you've done the right thing and looked at the scapula as well as the rest of the body. So what are you really, in your mind, what is this thing that you're seeing? What are you seeing? So I asked Dr. Hu and Dr. Stone to kind of give us an idea, as you see this, how are you formulating this? Not how you're going to treat it, but what do you think's going on here?
Well, I think Tim said earlier that's really important in the previous video that we need to check for obvious scoliosis. Okay, so we have to assume that that is not the case, and if it is, then you need to address that. And if you look at the scapula, the sixth scapular position, and we've talked about where you have the scapular malposition, the inferior medial border prominence, coracoid pain or malposition in the coracoid, and then the dyskinesis of the scapular movement is kind of the framework to start to evaluate the scapula. And then if you think about some of the muscle involvement in that prominent medial border, you're seeing decreased posterior tilt and decreased external rotation. And you're also going to see decreased serratus anterior and lower trapezius activity. So I think as you're starting to engage in this, you need to think about the muscles that are in front of you and what they're doing, because like we talked about in the previous series, it's not in isolation.
So you've seen this thing kind of sitting over here and you're starting to figure out what muscles, what causative factors may be going on. Tim, when you see it, what do you tell the patient?
Well, the first thing you have to do is have them appropriately draped so you can see their scapula. There's tremendous difference when you look at somebody from the rear. It's interesting. We sit and talk all day and we talk to our patients, but at that time you really need to stand behind them, which obviously all of us know that. But I think that's a valid point that we have to emphasize. When I look at the scapula, and since I've been around you for 30 years, I really started to change my brain about that this is a three-dimensional bone that has three-dimensional motion. Now, we've learned a lot over the years, and so I look at it in each of those planes. I think most people just look at upward rotation because that's the easiest plane, but probably just what you said, Dr. Stone, one of the first things I look for is how much internal rotation, how much forward posture do they have? And then the second thing I'm going to look at is how much anterior tilt. And when I'm looking at anterior tilt, do I see that wasting, worried about a nerve injury or something like that? To me, that initial motion, how they move in those first 20, 30 degrees, the setting phase, tells me a lot. Now, there's different approaches as we start to evaluate that. We can have them do it a bunch of times, or we can give them a little bit of load. A couple of clinicians actually have them push into a wall, not like a push-up, but down at their side, and it really becomes very prominent. You can actually see those bones sort of move under the skin as we go through that. So I think that first little bit of, do they have good control, and then what plane does or does it not move initially really helps me start to think about where I'm going to go with my other testing.
So Aaron, Jeff, you think, if you see it, what bells go off in your head? Maybe alarm bells, maybe not alarm bells. If you see this, do your ears pick up and you start looking a little bit more? I mean, how do you frame this problem?
Well, it's interesting because it always begins with what we see. And so you start to think, is this involved on the level that's actually contributing to the overall symptoms or the overall concern? And so I don't stop there, though, right? So none of us do. And so we have to go on and we employ what we call those corrective maneuvers, which is if we put this malpositioned scapula in a better position and ask the arm to do something, whether it's just actively move, passively move, or even resist us pushing against it in typical muscle testing, and all of a sudden symptoms improve or performance improves upon that. Now I start to play the game of, oh yeah, the scapula is involved or it isn't. And so, if those improvements happen, then the scapula is a player in this. If I don't get any improvement whatsoever or nothing changes, then I think maybe it isn't part of this equation.
Yeah. Jeff? Yeah.
And yeah, going back to the patient's complaint, right? They're there for a reason. And when looking at it, is like with this dyskinesis, how can it be playing a role in there, right? Is it the cause of it? Is it a subsequent effect of being affected by their complaint? Is where does this fit in the framework of this patient's complaint? And so that's where some experience certainly helps, but also the better understanding you have is what are going to be the downstream effects of this dyskinesis, this impairment.
So if you see it, first of all, as Tim said, you got to be in a position to see it first. But if you see it, do you all feel that it would ever be something that you would consider to be inconsequential? It can be. Would you say that it can be normal and just dismiss it? Or does it always require that next step if you see something there? Whether it's going to show it inconsequential or contributing. To me, I think you're obligated, if you see it, to make that next step to go through some of these things we're going to talk about next. Is that in agreement? I mean, you don't say, oh, well, that's just the patient, you know?
Well, I think you're right that you should investigate more. And I think if you have a little bit of suspicion, like if you talk about the scapular dyskinesis test, it's not just raise your arm once, right? It can quickly fatigue. And I think you need a little bit of repetition. And then also with the corrective test really helps you identify some of the pathology there. So I think you got to make the patient move their arm a little bit to really investigate that more. It's not always just staring you at the face. It may be more subtle.
Certainly a lot of people work with a lot of loads. So, some people are really muscular and you can't see that nice prominent border, and you got to fatigue them out, whether it's 3 pounds or 5 pounds or doing it 5 or 10 times. So sometimes it's sort of very similar to like this approach of evaluate and reevaluate. What you might not see it the first time, you might catch it the second time. We get that advantage in rehabilitation where we see the patient over and over again, and you might not catch it initially, and you're like, oh, I see that movement impairment. They're getting external rotation by arching their back, and their scapula is not stabilizing as well.
So that leads directly into the next question. That okay, so you see it. Now, what do you do about it? What do you do when you observe this problem? And I've hopefully made the case that you can't ignore it until you show me that you can ignore it by doing something else. So, Aaron and Jeff, what are you going to do? How are you going to approach this from a standpoint of evaluation?
So, like all clinical examinations, being thorough, right? Starting with the kinetic chain, start with the hips, start with the core strength, but then I'll also do my full shoulder range of motion, my strength, and then I'm watching the scapular motion. Okay, so when I see dyskinesis, then I start trying to correct the dyskinesis with a scapular retraction. Can they hold their shoulder blades back and position it correctly? Can they, if I hold it back for them, does it get rid of their impingement symptoms? Are they raising their arm better? Are they getting more motion? Are they getting more strength? And oftentimes patients will say yes. If that shoulder blade is involved, by getting them in that retracted, more stabilized position, they'll feel stronger. They'll have better motion. They'll have less impingement. And so that tells me it tries to give me a better idea of how much that shoulder blade is involved. How much is, if I see a labrum tear on the MRI, is it the labrum tear or is it this dyskinesis? If I can get them out of that labrum tear type pain with retraction and getting their scapula in a better position, it leads me to think this is more the dyskinesis, less about the labrum. And so the clinical exam is very important in trying to differentiate pathoanatomy and pathophysiology for me.
Yeah, it's a valid point. We have conversations a lot of the times where I say there's a difference between having pathologic symptoms and having the actual pathology, right? And so and the labrum is a great example of that, right? So you can have labral symptoms quite often because of the scapula being anteriorly tilted and internally rotated. And with the glenoid facing more forward, the arm's going to hit the labrum sooner than it should. All of a sudden, I got this nice compression issue going on that makes the labrum not feel so good. Right. And so, but if I get it back, now I don't have that problem. So very much a scapular position related entity in regards to having the symptoms, right? Versus the actual tear. Then, of course, you're going to see other situations arise because of that. Right?
Awesome. Tim, any other comments?
So I think the one thing that is important when you do observe it is that you look at it in a couple of planes. So what happens in flexion might not be what happens in abductions. The muscle roles change, right? We get more pectoralis minor in flexion. We get more activation sometimes of certain muscles, like the middle trap and the lower trap are going to work a lot harder in abduction than they do in flexion. So I think as you're doing that observation and they're asking their symptoms that you were just talking about, where are those symptoms? Is it more with flexion? Because I try to do that same retraction, but one of the mistakes I see a lot of young therapists make is they try to squeeze your shoulder blades back and lift your arms. Well, the scapula doesn't work that way. You can get it up a little bit, like 60 or 70 degrees, but at some point you've got to internally rotate the scapula and upwardly rotate, and that may or may not cause the problem. So we almost can aggravate it if we try to apply a single fix. We have to think about the different motions. So when I observe them, I really want to see where they're going in their function and then also in the different planes of motion.
Well, and I think, one thing that I've seen a lot more of in our more sedentary culture, especially with people spending more time on phones and computers and sitting forward, is the first thing I ask them to do is sit up straight. Because if it's an adolescent, they're not sitting up straight. So that may correct it right there. But oftentimes, too, you see a lot of more just anterior tightness from just very poor postural control. And that's been really exacerbated by people not being active or doing as much as they used to, or changes in that, especially as they get out of that active high school or college type age group and move into a more sedentary workforce and develop some of these challenging problems.
Yeah. So I think what we're saying, and I get this all the time, is that because as we've made the case, this is a comprehensive situation of activation and function, it can break down several ways in several different places. So the evaluation has to be pretty comprehensive. And the best way to do comprehensive is to do it in a certain staged way that you do basically consistently within variations depending on what you find. And so we have a whole video in this series on the exam of the scapula, which will give us some good ideas. And then I'll show you here, there'll be actually a 3-part evaluation kind of algorithm, if you were. The first is to decide whether the observed scapula dyskinesis has anything to do with symptoms. If it doesn't, then you don't have to worry about it. If it does, then as Dr. Grantham mentioned, how does it correlate with symptoms? And you do these corrective maneuvers. Then after you decide, okay, it does, then there's a stepwise progression of the evaluation of the pathoanatomy and pathophysiology that will allow us to kind of work through and almost like a checklist, kind of get the main culprits brought forward. So it's a little bit daunting, but really, if you do it well, it doesn't take. How long does a good scapular exam take you in your office? 5 or 10. I mean, if you do it, it's a screening exam, but it works pretty well. Now, you all take longer, but how just right off the kind of to get the general idea, how long would you want to have on that?
So if I have a good surgeon who's already evaluated that patient, if I have somebody with a little less experience, it probably takes me 15 or 20 minutes. But usually range of motion assessment is something we're going to measure a little bit more objectively with goniometry. Strength, lower trap strength, middle trap strength, serratus anterior. If we're doing this as a long-term sequelae, we might do some measurements of muscle strength or muscle endurance. Certainly, passive mobility of their glenohumeral joint is critical for internal and external inflection in those motions. It's probably a 15-minute examination, a 20-minute exam, depending on how many additional things we need to look at, because we have to also rule out something going on in the spine or something like that.
So the exam for the physicians usually is more of a screening and kind of make sure this, and that can be done to satisfy your understanding of what's going on within 5 or 10 minutes. Then we give it to you guys to really measure it and do something with it. So, but the idea is that don't sell it short. Do the right thing on the exam. Okay, so now we've been talking about hands-on, this kind of stuff. But let's look. Next question is, we like objective measurements. We like to have numbers. All right. So there's a question I always get: are there measurement techniques that can really do a good job of objectifying scapular position and motion? And if so, what are their values? So the rehab people, tell me some stuff.
Well, I'll just flat out say we have had an absolute time trying to figure out how to best objectify scapular motion in the clinical setting. It has been a bear of a task, and mainly because it's what we mentioned earlier. The complexities of these sets of motions just makes it very, very daunting. And so you have this ellipsoid thorax, which makes things difficult from the start. We think typically when we're talking about anatomical motion, we think in terms of our straightforward planes, but the scapula doesn't move that way, right? And especially around a rounded thorax, that just isn't going to fly. And so we're crossing planes, we're going on diagonals, and so to really come up with a way to put a number on this motion has been hard. And so really where it began from a biomechanical sense was in the three-dimensional kinematic world, where that it allowed for great objective way of measuring. The problem is it takes many, many minutes, if not hours, to set up and collect and process. And for one patient, that just isn't feasible. And so we've tried to come up with more clinical ways of doing this. And we went into the world of inclinometers. And unfortunately, the earlier inclinometer measurements only allowed us to do upward rotation. And so if you have an inability to collect on all the other kinematic motions, does only upward rotation tell you anything? Not so much. Right. But then there's been some advancements, and so Tim can really talk about those.
Yeah. No, so I think that's really an important. Our little handy dandy phone. We now have these little range of motion measurements, and we can say, okay, I'm tilted anteriorly, or I'm tilted upwardly rotated a few degrees. So it has come along that we can get a couple of the motions. But Aaron's exactly right. The biggest problem is transverse plane motion. So if we think of the scapula of posteriorly tilting and upwardly rotating, what kills us is the transverse plane. So in the last 5 to 10 years, wearables have really become very much popular. So in our little handy dandy phones and on these wearables are IMUs. IMUs are initial measurement units. Those are what keep the drones from flipping upside down and falling down. So those inertial measurement units are now starting to be popularized in different systems. And so one of the advantages of the IMUs, and this is a device that allow us to go any plane. We can go in a 45-degree angle, call that 0, and stay in that plane, which is much more consistent with what you're talking about with scapular motion. And so there's been a lot of research looking at inclinometers that give us a number, but it is relatively single plane, one at a time, sort of a very controlled motion. Way too slow for many of my physician colleagues. Mm-hmm. But we do have ways of measuring improvement, and our job is to show that the patient got better, that they gained range of motion. So there are some objective measurements. These inertial measurement systems are now getting popularized, where we can put them on a shoulder or put them on an arm. We're doing all kinds of research at our university looking at these with lower extremities, but now it's starting to move on to the upper extremity. So it's becoming more, if we do set planes of motion, flexion, scaption, abduction, we might be able to do a little better job of starting to capture true dynamic motion. But it's an evolution. 2000, we published the clinical observation paper. At the same time, McClure and Ludwig were doing these bone pin studies with 3D motion. The folks up in Michigan were doing the dual X-ray assessment of scapular motion. So in the last 20, 25 years, this whole area of scapular motion research has really exploded. So I think in the next 5 or 10 years, we'll have simpler ways to give you all objective numbers.
Yeah, we want we want objective numbers as the initial assessment, but really what we want is this test, retest, or this, how you doing down the road with numbers, because you can't do that with the objectives right now. There's CT scans. They're doing that over in South Korea. I mean, there are a couple of units that are getting pretty well categorized, that they actually are measuring with the skin placement units, that they're actually correlating with the actual scapular motion. That's one of the other problems, the lack of precision. So, but at this point in time, would you say that any of these things are routinely advocated for the clinical usage? Are they that good yet? Are they not ready for prime time yet?
Well, we had a paper that got accepted that recently that's a pretty straightforward, but they're all atypical. I would say the typical way people are evaluating it is using some of the observation systems that we've created, or what Phil McClure has created with a weighted system, and just describe that. But it's not a routine clinical assessment with a range of motion measurement of 20 degrees of posterior tilt or 40 degrees of upward rotation.
Are you satisfied that the qualitative observation method that we and McClure talked about will put you in the ballpark that indeed there's scapular dyskinesis present?
If they have symptoms.
Well, I mean, they'll show scapular dyskinesis.
It'll show scapular. I guess it'll be more meaningful in treating a patient if they have symptoms associated with that. But yeah, you could probably say, you could walk down the beach and say that person has scapular dyskinesis or not.
I'll watch them on the tennis court and watch them.
Yeah. But I agree. Yes, it's probably not routine yet.
Okay, well, last question that we have on this session right here. I'm going to throw it over to our surgeons. We talked about the muscles. We talked about the motions. And this bone does not just sit there in no man's land. It's attached bony through the AC joint and the clavicle to the axial skeleton. So as a result of that anatomy, we have to consider alterations in those systems as well. So why do you evaluate the clavicle and the AC joint in a patient who you see has scapular dyskinesis? Surgeons, well, let me know about it.
Well, I think the important thing about the clavicle is that it does attach the scapula to the axial skeleton. That clavicle is a strut. It helps keep the optimal scapular length and the placement of that bone through range of motion. And the clavicle is not a static bone. It's very dynamic. It has two joints, the sternoclavicular joint and the acromioclavicular joint, and there's movement through both of those joints. And so I think that if you don't have that strut and you don't have that bone, then you have a problem. And so that's one of the reasons why you really have to look very critically at its attachments, assuming there's no fracture. And we'll talk about fractures here in a second.
And yeah, when you see the patient with the fracture with the AC separation, how do they come in? That shoulders droop, it's internally rotated. That immediate injury to the AC joint, the clavicle, threw off that shoulder blade immediately. It shows you how important it is in the function of that shoulder blade.
Yeah, so you've got to look at it from a standpoint of several functions. First of all, it is length, medial to lateral length, but it also, because of its S shape, then it becomes a crank. Less motion at the SC joint creates a lot more cone of motion at the AC joint, which then allows for these motions and positions. And I'll advocate that either a clavicle fracture or an AC joint injury is basically mechanically an AC joint injury, because it damages the strut function of the clavicle or its attachment to the scapula. And so what does that mean for treatment then?
We're going to put it back together. So if you have compromise of that strut, then you have a floating bone there, right? That is the attachment to the exoskeleton. So you have three-dimensional motion through the sternoclavicular joint and the acromioclavicular joint. There's 3D motion there. So if you have a break in that system, then you've lost that connection and you've lost the downstream effects of that motion. And we know that if you have a clavicle fracture, for instance, a lot of those are going to heal. They're most commonly midshaft. They're going to heal shortened. And then you lose that crank arm. That is an inefficient crank and less effective. And you see some of that result at positional deformity or potentially static deformity, depending on the severity of the injury. And so I think that's one of the reasons you have to restore that crank length.
And, there's a debate, maybe in the younger kids, maybe you can get by with a little bit of this, but in adults, a union of a bone does not equal function of the entire unit. And worse than, in my mind, than the shortening is the malrotation, because this distal fragment will always anteriorly rotate, which then guarantees, as Jeff said, a protracted position, which is difficult to get out of, and your rehab guys can't make it that much better.
No, I had a young lady that presented to me, equestrian athlete here in Kentucky, and had fractured her clavicle 13 years ago and was having significant problems and had to have a significant clavicle osteotomy to reconstruct that. She's like, you know about scapula, come fix me. I'm like, no. Here, go see orthopedic surgeon.
One of the most interesting things is, where did she hurt? She didn't hurt here.
Not in her fracture.
No, she hurt in her periscapular muscles. All this upper trap, because of this almost thoracic outlet type position right there. Yeah, and all this upper trap pain and serratus pain, they had a lot of pain back through there. All right, what about AC joint injuries? You say, well, you just leave it alone or cut it off or fix it. Even if you're going to fix it, how are you going to restore this complex motion to let it work right?
So yeah, the AC joint's a little more complex, right? You have the AC joint, you have the CC ligaments that both do anterior to posterior translation as well as inferior and superior translation at the CC ligament. So in doing any kind of reconstruction or repair, you got to recreate the anatomy because there's a purpose for that anatomy. And so recreating those CC ligaments, trying to put them anatomically back to the clavicle, and then also extending that out to the AC joint. Okay, I'm a big proponent for repairing or reconstructing the AC ligaments with any CC or AC separation type reconstruction, because that anterior to posterior translation is very much important for that scapula feeling stable and good function down the road.
I think you hit on it there too, that the CC ligaments, they actually do help control the clavicle, right? The trapezoid ligament is going to retract the clavicle, or the coronoid protracts the clavicle. So simply drilling a hole and putting a single static ligament is not really recreating the anatomy, like you said. And then you have to address the AC joint capsule itself. And to really create that stability and restore that strut but functional crank form.
We talk about all these muscles that work on the scapula. There are very few muscles that work directly on the clavicle. So basically, the clavicle motion, which is, we've talked about how important it is mainly driven by scapular motion transferred force through the CC ligaments and the AC joint. So if you don't have those right, then you're going to have an approximation of clavicle motion to achieve this function into there. Any more thoughts about that?
Well, I think that's the most important thing. This is not something we can rehab, right? So people ask me, like, I have an AC separation. It's not like the rotator cuff. I got 4 muscles I can do something with and stabilize. I have maybe a little bit of the upper trap and a little bit of deltoid covering that, but I don't really have anything to work on. One of the reasons that I love treating shoulders is there's so many other muscles you can overcompensate, but not at the AC joint, not at the clavicle.
Yeah, we're doing a very interesting study at the associated with the American Shoulder and Elbow Society on AC joint treatment, and we're looking at complications and where they come from. And the vast majority of complications, meaning loss of reduction, requiring more surgery, is an unanatomic placement of the CC ligaments and or non-anatomic attempts at fixing the AC ligaments, showing the importance of these ligaments in the entire system. Remember, this is a system, and if we lose sight of that fact, then we are going to have less good outcomes. Well, thank you all very much. This is the most common questions. You probably have some more, and that's fine, but these are the questions we get a whole lot. I want to thank the people, our panelists on the roundtable, for this excellent discussion. Once again, we got a video on the clinical exam of the scapula as well, and we're going to have some more videos on actual rehabilitation of the scapula and some of the more detail about the scapula and the throwing shoulder, the scapula and these injuries to the strut. So just keep tuned in on it. And thank you very much.